Thank you, everyone. I really want to thank the committee for inviting me, and definitely have to say I want to thank the faculty. I kind of feel like a academic integrative medicine groupie being around such luminaries, kind of the rock stars of the field. So it's a pleasure to be here. I bring the perspective of a family physician as well as a director of an integrative medicine center that largely focuses on non-pharmacological care within a 5-hospital system at Scripps. So I'll bring those perspectives and a little bit of what I've been able to do with work abroad in Taiwan and other places, looking at their healthcare system and expansion of non-pharma care there. So the barriers, we've talked about all of these extensively. I just want to mention some details of these. I'm going to lean heavily on the VA guidelines that was mentioned in the last panel. I think they did an amazing job looking at various barriers and potential solutions. And I think we do need education not only of providers, I think that's very important, as Penny mentioned, but also patients and payers. I think on a patient side, it's a lot, as this article from the SPACE trial was a follow-up qualitative discussion with the patients who benefited. And the quotes that came out, I was really surprised. In many cases, patients, similar to providers, have this pedestal of here's opioids or other stronger treatments, and here's sort of the other non-pharma care. And we need to sort of do some education on not just the evidence, but really this can help transform your pain. I think access we've talked about, but more importantly, who do I see? How do I access that person? How do I know they're good? And coverage. We already referenced this earlier. It talks about, other than unimodal physical therapy and chiropractic care, multiple other therapies are either not mentioned or not explicitly covered. And so when I get that denial letter for biofeedback, which is in the ACP guidelines, I have to do the Rob Saper shoulder and breath, deep exhalation, while I get my appeal letter ready. So let's talk about change. The solutions, again, we're not here to provide recommendations, but I think one area that I think we need is culture change, that was mentioned earlier. And again, the VA had really good wording, a national educational campaign. And so what does that look like? I think in the VA, because they are able to do so many good things as part of their system, what does that look like outside the VA? And I think we need a national education campaign. We probably need a national education spokesperson. I have some bets on who I think would be good. My bet is on Oprah. And the reason I say that, does anyone remember when she did acupuncture? She received acupuncture on air several years ago, I think by a PCOM grad. That was a sea change of people feeling comfortable. Well, if Oprah can do it and it's helping her, guess what? That trumps any randomized trial. So I think we need a campaign that's real world, speaks to patients from a voice that they trust. I also think that we do that in our system. I'm part of the opioid stewardship committee at Scripps, and we meet and put together tools both for patients and providers. Those are important. And we try to answer important questions, but every time we try to come up with a questionnaire or a resource, I always think this must be done somewhere, probably at the VA or somewhere else, and I need to find that. And it would be great to have a national, maybe clearinghouse of these educational materials that we could use in all our systems, not just in one system here or there. That would save a tremendous amount of work. And the educational tools we're trying to put together really are looking at not just is this evidence-based, but it can have real-world impact, and maybe putting patient examples of here's someone that they can see getting these treatments, and here's what it actually looks like in the real world, not just your primary care saying, go get some acupuncture, and that's really foreign to a lot of our patients. I also think that needs to be started very early. We're typically seeing some of these patients ninth inning, 2 outs, and just like in Western medicine where we have time to an intervention, whether it's angioplasty or other things, what's the time to non-pharma care? And it should be a very short period of time as opposed to what we're seeing. With access, I think the concept of cancer navigator is there, diabetic educator is there, but what about a pain navigator or educator? We've talked about it in other circles, but I think that's really important to consider. Somebody that could be a nurse, a health coach, and maybe an integrative expert in some arena that could help guide them and also work with coverage and navigating the insurance issues. The last area that I want to talk about, these are 3 big areas, are nutrition, prevention, and provider empathy. So we've done a CME course that's provided some ability to change perception of, can I educate on nutrition? I think prevention we've talked about, looking at the school-age population. And finally, empathy. When we actually help patients or providers reduce their burnout potential, it improves the discussion and actually helps patients feel like they are being listened to. So I'll end there. Thank you so much.